However, endocardial mapping ablation might be precluded by the presence of a huge LV thrombus, which is much more common in patients with LV aneurysms after myocardial infarction. In the mobile thrombus formation, the clear contraindication to endocardial mapping and ablation. In contrast, evidence of a laminated thrombus is not a clear contraindication. However, mapping might be limited, and even irrigated tip catheter ablation is unlikely to produce any sufficient lesion in an area covered by such a huge thrombus. So epicardial ablation offers the potential to treat these patients regardless of intracavitary obstacles. So our patient is a 74-year-old male with experienced antiomyocardial infarction without perfusion therapy. The coronary angiogram performed 2 months later revealed an open infarct-related artery with a radial lesion, a significant lesion of the circumflex, and he underwent PCI of the right coronary artery. So the LRD was not treated because there was no evidence for reversible ischemia at nuclear imaging. 1 year later, we presented with recurrent sustained ventricular tachycardia poorly tolerated. And coronary angiogram revealed progression of coronary artery disease with now a significant lesion of the right coronary artery. On echo, we had an apical aneurysm with a thrombus formation, and in contrast, enhanced MRI, an apical scar with more than 70% scar transmorality. On Unit B study, we could induce 2 VTs with very similar cycle lengths, and VT1 was a clinically documented VT with a left bundle bench block type morphology. So he underwent PCI of the right coronary artery, and ICD was implanted and he was put on oral anticoagulation therapy. 1 month later, he presented with recurrent VTs which were terminated by the ICDs, but nevertheless VT ablation was offered.